Okay. Hello, it's great to see you all the last time before the summer for our Modeling Biocomplexity seminar focused on cancer invasion and progression. This is the 7th and last session. And I would like to introduce the organizers, Lutz Busch, Robert Müller, Simon Seeger, all from the Department of Innovative Methods of Computing, TU Dresden, Technical University Dresden, focused on modeling medical problems. Today, it's a big pleasure to welcome Bob Gatenby. Before he gets the word, I would like to shortly introduce Bob. He has a major in bioengineering and mechanical sciences from Princeton University and an MD from the University of Pennsylvania. So he has a nice background in medicine, especially cancer. He has board certifications, particularly from the American Board of Radiology. And today he holds different positions. He is a department chair at Moffitt Cancer Center, and he has also a professorship at the Departments of Oncologic Sciences and Radiology at University of South Florida, Tampa, Florida. Bob has more than 250 reviewed publications, many dealing with cancer, medical aspects, theoretical aspects. And today we are very much looking forward to your talk, Bob, on evolution-based models to control and cure metastatic cancers. As usual, you have a word now for approximately 45 minutes. Afterwards, there's possibilities to discuss, and all the participants can put their questions in the chat channel YouTube or questions and answers Zoom. That's from my side. Bob, thanks again for accepting our invitation, and we are looking forward to your presentation.
Thank you, Andres. Should I share my screen now? Is that what you want me to do? Or can you see it? Hello, everyone. I'm hoping that you can see my screen, and Andres, if you could just make sure that if that's not the case,
please, we can see your screen.
Great.
We can see it.
Thank you very much. Just as a quick introduction, Moffitt Cancer Center is actually the 3rd largest cancer center in the United States, and has, I think, the distinction of having a full-out mathematics department. We actually have 9 mathematicians and 2 evolutionary biologists who form a theoretical core for what is really a physics paradigm where we're trying to bring theoreticians and mathematically based theoreticians into clinical therapy and cancer biology. So I will now, we go on. And so this is very much the goal here. It's to view cancer as a complex dynamic system with multiple nonlinear interactions. What we've done is to use the physics paradigm to link mathematics and theory with experimental and clinicians. The core of what we do is actually on the 4th floor of a building in which we house the mathematicians, evolutionary biologists, clinicians, and experimentalists. And the core of this is shown here on the right. It's what we call the collaboratorium, a place where mathematicians and non-mathematicians can get together, talk about cancer biology. biology, write down equations on wall-to-wall blackboard, but also discuss experiments. We have a unifying first principles framework, and that's on evolution, and that's developed over the last 10 years. And so now the Integrated Mathematical Oncology Department at the Moffitt Cancer Center has 9 full-time faculty mathematicians and 2 evolutionary biologists, again, to form the core of theoretical applications in cancer biology. So I'm going to talk really about cancer treatment. And a lot has been made recently of this idea of personalized cancer therapy. And this is a very good example of this. This is a CAT scan from a woman who had metastatic lung cancer. They did the genetic analysis of the cancer and showed that she had a mutant EGFR driver gene. And as a result, a specific therapy, erlotinib in this case, although there are others now, was applied. And you can see the same region several months later shows a very successful response. Some, probably areas of tumor remaining, but nevertheless, a really dramatic response, and really it's kind of a triumph for this concept of personalized medicine. What you tend to not see, though, is that a few months later, you continue to give therapy, but you now see tumor progressing. And the problem is that no matter how focused your therapy is, no matter how successful it is, nearly always the cancer learns to evolve resistance, and as a result, that therapy becomes ineffective, and basically the patient will go on to die. This metastatic cancer remains a fatal disease. So my contention is that the second half of the graph, this evolution of resistance, which has been regarded rather fatalistically by oncologists, is really also very personal, and also can be understood and can be manipulated in ways that allow the patient to continue to respond or respond better to the existing therapy. So let me give you a kind of a very brief review of standard dogma in cancer therapy. And it's basically fairly straightforward. Drugs or drug therapies are given essentially consistently, continuously, at maximum tolerated dose until progression. So what does maximum tolerated dose do? Well, it's very good at getting rid of the cancer, but it's only the cancer cells that are sensitive, because cancer populations typically are in the range of 1 billion cancer cells per cubic centimeter of tumor. We're dealing with a huge population. These are highly diverse, both at phenotypic and genotypic level, and therefore it's highly likely in a population that large and that diverse that there are going to be pre-existing cells that are either resistant to begin with or can very quickly adapt to a resistant phenotype. And so when you give maximum tolerated dose, as effective as it is, it's always also sowing the seeds of its own failure, because what it's doing is strongly selecting for resistance while eliminating all of the sensitive populations through this sort of maximum application of treatment. And so you can continue to give the therapy, but it's futile. What you see then is that inevitably the cancer progresses. 2 phases of this, and we'll focus primarily on phase 1, which is the interspecific evolution. In other words, here you have the resistant population and the sensitive populations competing with each other. And so as that goes on, we have we try to exploit that. Once you have only a population of resistant cells, you begin to get intraspecific competition. In other words, these guys are now competing with each other. Resistance is assumed. And what they begin to do then is to compete with each other to increase proliferation rates within the context of resistance. And so as a result, by the time you see a population that's resistant, it's also been competing among itself to optimize the evolutionary dynamics of that and optimize proliferation. And this becomes an important part of our kind of understanding. So I'm going to show you a simulation. This was a simulation by Tamir Epstein, who is actually in Amsterdam right now. And just consider this a cancer population. The X is really a metric of phenotype. So what we're seeing across the X-axis is a diversity, and on the Y-axis we're seeing a number. And for the moment, let's just assume we're going to apply a single perturbation, a single drug or group of drugs to this population. And so you'll see this happen. Now, you'll see as we go, this is just kind of drifting there. And there's the application of the therapy. And it's really effective. I mean, the tumor's population has been tremendously reduced. But you'll also see at the edge that there is a group of cells that are resistant, a small group. But as we continue, you can see that even as the population continues to be treated, the tumor population comes back. So what's happening is you keep treating it, but you're treating resistant cell populations. So there's no effect. Now we're not going to apply any therapy. And watch what happens to the distribution of the cells on the x-axis. You can see as we go on, in the absence of therapy, we begin to see this right to left drift as the initial cell population begins to reproduce itself. This is the evolution that we are exploiting here. The population that is resistant is very small. The reason is that the cost of whatever the molecular machinery of resistance is significant, and as a result, they are not as fit in the absence of therapy as are the ones that are sensitive. However, they are there as a small population, and in the presence of treatment, they are the ones that are most fit and therefore the ones that proliferate. But when you remove therapy, the cost of resistance then begins to affect the interactions between the resistant and sensitive populations, such that the sensitive cells are fitter in the absence of treatment. And so you're seeing here the recapitulation of the original population distribution. On the right, you can see an experimental example of that. We have two populations of cancer cells. One is resistant, one is sensitive, one has been evolved to become resistant. Otherwise, they're identical. When you mix them together at a 50-50 distribution, and you put them in an environment that is similar to the substrate poor environment that you see in in vivo cancer, the sensitive population very quickly proliferates and drives the resistant population to extinction. And that's the dynamic that we want to exploit. And so there are many ways to do that, but what I'm showing here is what's been called adaptive therapy. And if you just follow this line left to right, you start with a population of cancer cells. Most of them are sensitive, but a few are resistant, and you give therapy. Here, instead of giving maximum tolerated dose, where you want to kill as many cancer cells as possible, you only give enough therapy to somewhat reduce the population of sensitive cells, but you deliberately leave some of them behind, and then you withdraw therapy. What you do, as the tumor then grows again, that you can see the absence of treatment. There is no selection for resistance. As a result, the sensitive cells can use their fitness advantage to proliferate at the expense of the resistant population. So, although the tumor comes back, you also recapitulate more or less the phenotypic distribution that you saw pre-treatment. And as a result, you can apply the treatment again and again and again and again. And so, this idea then of simply using the cancer cells you can control to control the cells you can control is kind of the fundamental idea here. And again, there are many other ways to do this, but this is the one that we have focused on in terms of our clinical applications. Now, I should tell you that this is not terribly popular among oncologists, at least it wasn't at the beginning. And what I'm showing you at the bottom is a typical response that I would get from a very angry oncologist after I gave a talk. And what he was saying is that this is, you know, you can see what he says, but his concern was really that what he needs is better drugs. And this focus on drug development, on finding better drugs, rather than thinking about strategies to use existing drugs, is really quite extensive in the oncology world. And we'll talk more about that later on. So this is the sort of treatment. And now one of the questions that came up is that would appear to assume that there's a spatially well-mixed system. If you see regions of tumor that are sensitive and resistant, where they're not overlapping, can you get similar effects? And I'm just showing this as we've actually done some extensive simulations to show that physical separation still allows the kind of benefit that we saw in the previous slide. And so our initial application was in metastatic prostate cancer. About 1 out of 6 men in the world will get prostate cancer in their lifetime. Most of them will be cured by surgery and radiation therapy, but in a significant fraction of those men, the tumor will spread typically to the bones. You can see this is a CAT scan image, and the white areas in the spine and in the manubrium and the sternum are all metastases. Metastatic prostate cancer is fatal. There are no survivors of this disease, but it has a number of very effective therapies, and I'm going to show on the right a kind of a typical timeline. Someone might get a local therapy, and then they develop metastatic disease later. The initial therapy is called androgen deprivation therapy or chemical castration. Essentially, you eliminate all of the androgen, all the testosterone in the body, and typically the tumor responds tremendously. 95% of the time, the serum marker for tumor volume, which is PSA, goes to normal, and sometimes it will become undetectable. And that time will last for perhaps a year or two. So they will continue to give androgen deprivation therapy at maximum tolerated dose. And eventually, the tumor becomes resistant. And then you see, again, this upward of the PSA, and a second therapy is applied here. These are called now castrate-resistant population. Now, I should point out that there are a couple of ways that the cancer can become resistant, but the most common way is the cancer cells themselves begin to make testosterone. And so now there are some drugs available for that, and those are the drugs that we're going to focus on. So we begin with developing a model, and I just wanted to acknowledge people that did this. Reynolds, Joel Brown, who's is an evolutionary biologist, and Katrina Stankova, who is a mathematician in Amsterdam. And so what we did is define 3 subpopulations. The first subpopulation is the one that needs exogenous testosterone. This is the one that was the dominant population in the initial prostate cancer. It was treated with the chemical castration. Most of those cancer cells are now dead because of therapy. T cells are the ones that can make their own testosterone. These are the ones that can then arise as a strategy, as a resistance strategy for the androgen deprivation therapy. And then finally, there's a group of cells that can proliferate independent of testosterone. So we define these based on their interactions with testosterone. And you'll see one thing that becomes very clear is that the cells that that can make their own testosterone also spill it into the environment. And you can have what are called cheating dynamics, where the T+ cells, which require exogenous testosterone, can begin to use this testosterone made by this other subpopulation to permit proliferation. And of course, that brings in some really interesting dynamics. because of course they can benefit from the testosterone production while not actually bearing the cost of it. And these idea of public goods and cheater dynamics, I think, is probably important in some of the ways that we see the dynamics going on clinically. So we developed a standard kind of Locke-Volterra equation approach, and we used matrix games to look at the drug that we used is Abiraterone, or that we focus on is Abiraterone. Abiraterone blocks androgen production by prostate cancer cells, so it directly attacks the TP cells. And in large trials, you get quite a good response rate, although the time to progression, meaning the time to when you have to switch therapy and go to something else, is 6 to 12 months. And so Dr. Jinsung Zhang was the very courageous oncologist that began this trial. So you begin with an initial administration of Abiraterone. The PSA, which is the serum biomarker, when it falls to 50% of the pretreatment value, we stop therapy. Therapy is entirely withdrawn. And then we retreat PSA only when we retreat with Abiraterone only when the PSA returns to the pretreatment value. Mathematical models that I showed you suggested that this would be an effective therapy, and that depending on initial conditions would control the tumor for between 2 and 20 cycles. This is in fact what we've seen. In most of the patients, we see cycles that are in the range of 3 to 4 months, but the cycle time can be tremendously variable and can occur actually over years, 18 months, for example. So it is quite variable. We have seen nearly all the patients went through a cycle or two. We have patients that are up to 12 cycles over almost 4 years of this kind of therapy. And so I'll give you the latest out in a minute, but I do want to show one thing that our models did not predict, and that is that in about a third of the patients, what we see is that you give Abiraterone, PSA declines. We withdraw Abiraterone, but the PSA does not come back. PSA, in fact, drifts in a range, sometimes going down a little bit, sometimes going up a little bit, but it can drift in that range for a year and a half or two before it begins to come back up again steadily, suggesting that there is that in some patients, by reducing the population size, that you can get into a new steady state, which can result in relatively prolonged stability of the cancer population, even in the absence of therapy. This has become more interesting to us as time has gone on, and I'll talk about that a little bit later. But for the moment, we now have we've actually completed the clinical trial. It included the 20 patients that we had wanted to do. The results are pretty much shown in the upper right. We had a control. These are patients that would have been eligible for the trial, but instead of the adaptive therapy, got the standard maximum tolerated dose of progression. Their time to progression was about 14 months. In the adaptive therapy group, their time to progression is about 33 months. So there was quite a big difference. The adaptive therapy patients received only about 40% of the amount of Abiraterone that they would have received had they been getting full doses. And that's important in part due to toxicity, although Abiraterone is not terribly toxic, but it is important in terms of cost, because Abiraterone therapy, at least in the United States, typically costs about $6,000 a month. So it was tremendous cost savings. And in fact, this was analyzed, and it was found that on average, patients, there was a $50,000 per patient per year cost saving from this approach. The other thing that we found to be very valuable is that because a mathematical model was used to design the treatment, we could use that mathematical model to understand the dynamics of every patient, and we could retrospectively look at all of them and try to understand why they progressed, how we could have done it better, and what we did wrong. And so this is called an after action analysis. And what we did essentially is to run the model backward. Once we knew the outcome of every patient, we could go backwards and say, well, what were the initial conditions that gave us those outcomes? And then run the model forward again and say, well, what could we have done better? And so this is an example of a patient who progressed after 6 cycles or 30 months, which is quite a good response. This is the what we saw. We've recapitulated now how the clinical observations with the model so that we understand what initial conditions were. And then we went forward and this is a very simple change. Suppose instead of waiting until the PSA dropped to 50% of pretreatment value, suppose we just waited until it dropped to 80%. So now we have a smaller decline. And the reason that we thought that might make sense is that because what we were finding in the models was that every time the patient, the PSA dropped, every time you had response to therapy, there was always a little bit of growth of the fitness of the resistant population. And that growth ultimately over 6 cycles was such that you couldn't then control the patient. If we only wait for the 20% decline, so we have a higher initial number of sensitive cells, and that further decreases the proliferation of the resistant ones. And so what we found was that although we had much shorter cycles, that we could actually maintain the patient, in this case for 58 cycles, 270 months, really essentially his lifetime, since prostate cancer is a disease of elderly men, being it under control for 20 years, more or less guarantees that they will die of something else. We can look at other types of things, but suppose we now said, suppose we start treatment when we start this adaptive strategy in the initial treatment. So when androgen deprivation therapy started, and we used this adaptive approach, and we used as well this adaptive approach in Abiraterone. So suppose we just add the adaptive approach in androgen deprivation therapy. You can see that we went from this is kind of where we began the Abiraterone therapy before. Now we can go for almost 8 years before having to give Abiraterone. Now suppose that instead of this, we gave Abiraterone at faster, instead of 50% decline, ADT and Abiraterone, not just 50% decline, but 80%, but 20% decline. Can we see this kind of approach? And what we found was that this kind of approach in a typical patient, this is a typical kind of scenario, could increase the control of the tumor for years. And so, again, as in an elderly population, that's pretty much sufficient to eliminate it as a common. With that in mind, I'm going to change and quickly go through another topic which has kind of emerged from this. And if people in the audience are involved in cancer treatment, you'll know that at any number of parties or family gathering, someone will corner you and say, so when are you guys going to find a cure for cancer? And in many ways, this comes from the pioneering work of Ehrlich almost, more than 100 years ago, where he talked about this magic bullet, this idea that you could find and identify a treatment that selectively kills the cancer while not affecting normal. This magic bullet became even more convincing as a paradigm with antibiotics. And so I would argue that when we think about finding a cure for cancer, we tend to think about it as a thing, some drug, some magic agent that will cure it. And I would argue that, in fact, we're not going to find a magic bullet, which is not to say that we can't cure cancer, because I think the cure for cancer is not a thing, but a tactic. And so I'll just try to convince you of at least the reasonability of that next few minutes. So remember the angry oncologist that I talked about, and I think that you could see what his comments are. It's really about drugs. You know, it's really about drug development. We just need to find better drugs. So I will tell you that I started this with the underlying paradigm that it was not possible to cure cancer, that you could not possibly eliminate such an enormous population that's both phenotypically diverse. It would seem insurmountable. There's a couple of things that happened. One was this observation that I pointed out earlier, where once you gave Abiraterone and the population declined, it didn't come back. Even when you took Abiraterone away, it would sit there for years, suggesting that it has achieved some kind of new steady state. And what is that steady state? The other thing is I began to work with a pediatric oncologist. He treats, this is Damon Reed, he treats young adults with metastatic coma. We started talking about using adaptive therapy in this group. Now, this is very unfortunate. These are usually teenagers. Once they get metastatic sarcoma, nearly all of them will die of this disease. But initial therapy is extremely effective. Similar to what I've showed you before, tumor virtually melts away, but then nearly always comes back as resistant and they die. So we thought this would be a very good clinical situation for adaptive therapy, but we got a tremendous amount of pushback on the oncologists, because they said, we're pediatric oncologists. We're talking about teenagers. Prolonging their life for several years is nice, but we want to talk about cure. We're about cure, and so go back and do better. The other thing that I learned as I was talking with the group is that there are some outliers. About 3% or so of kids with this disease survive. So it's a non-zero extinction event. And so could we in fact use these outliers to do better? So in thinking about this, and this was certainly not new to me, the idea of cancer cure as an extinction is something that's been discussed. And so if metastatic cancers are clade, they're large, diverse, spatially dispersed, and asexually reproducing clade, is it possible? Can we think about extinction? And one of the things that I realized is that when we talk about extinction, we always think about dinosaurs. This idea of causing extinction by the application of massive evolutionary force. But this idea of brute force is limited by this kind of indiscriminate effects. So while the KT impact, did extinct the mighty dinosaur, it also destroyed about 60% of other land animal species. Now, arguably, the cancer therapy has elements of this idea of the dinosaur extinction, this idea of massive application of cytotoxic drugs, this idea that we will kill as many cancer cells as we can with a single event, a magic bullet. But the problem is that any application of evolutionary force is indiscriminate, and so it will always kill normal cells. And as a result, we're always limited by this toxicity. But so let's think about the dinosaurs again. So you have this initial event, this KT impact, and the population decline. And this has been called a race to extinction. You can see the decline of the population. But in the race of extinction, there's really two forces. One is that you can simply go on the population can dwindle or die. But there's also this possibility of what's called evolutionary rescue, meaning that during this decline, there will be uncovering of individuals that either fortunately or unfortunately were, or by pure chance, were resistant, and could survive and then proliferate and recapitulate. This idea that it's not a single event that's inevitable, but in fact one that has several different outcomes. This idea of evolutionary rescue focuses on the issue of small populations. And this is actually an area of tremendous interest in evolutionary biologists. So one of the things that's become very clear during the Anthropocene era, which is the era in which our species has continued to destroy other species, is that extinctions are not typically single cause, single event like the dinosaurs, but in fact, background and Anthropocene extinctions are far more subtle. They involve multiple steps, multiple causes, and those, but they're also highly species specific. And because of that, I felt this kind of dynamics became more interesting in terms of cancer therapy. So humans have caused many recent extinctions, and just look at the passenger pigeons, population in the billions. Rocky Mountain locust, population in trillions. And we also have experience with intentional Anthropocene extinction, like the Galapagos goat. And if you start to look at that, you begin to find patterns that I think are relevant. So the heath hen is a good example, and I'll just briefly go through this. Heath hen was highly populous in the eastern seaboard of North America when the European settlers arrived. A fun fact is that they were actually fairly tasty, and the American Thanksgiving, the initial Thanksgiving on the Pilgrims actually probably didn't eat turkey, but they ate heath hens. So they were hunted, and human habitation began to encroach on their habitats until the mid-19th century, when they were reduced to a single population on Martha's Vineyard, which is an island off of Massachusetts, and only 50 individuals were present in that colony. The human population decided to make tremendous efforts to conserve them, and by the early 20th century, 2,000 of the heath hens existed. But then there was a sequence of unfortunate and unpredictable events. There was a small fire in their habitat. There were two harsh winters in a row, and there was inadvertent introduction of a poultry disease. None of these events would have significantly affected the large population that occupied the entire seaboard. But in this isolated small population, the sequence of events caused a series of declines, ultimately leading to the extinction of the population. And so this is actually very much the kinds of things that thinking about in terms of cancer. There's a first strike in the case of the heath hens. The population, which was large, dispersed, and heterogeneous, was reduced to one that was small, isolated, and relatively homogeneous. The first strike did not cause extinction. What it did was reduce the population to one that was very small and then therefore vulnerable. And the reason is that small populations have been found in nature to be subject to extinction due to their unique vulnerabilities to stochastic perturbations and effects. And this becomes a self-reinforcing dynamic, because as each of these perturbations pushes the population smaller, it becomes increasingly vulnerable to additional stochastic perturbations and all the effects. And the evolutionary biologists have called this the extinction rule. In other words, a sequence of perturbations, none of which would have substantially affected the initial large population and cause the small population to inevitably go to. In terms of cancer, how do we sort of look at this? And first of all, cancer cells evolve. What I'm showing on the left, these are different regions of the same breast cancer. Ki67 is a metric of proliferation, and CTG is S-space, which is a metric of cells that are dying. Cells are living, and birthing, and dying. That's the fodder of evolution, and you'll notice that these change tremendously. This region of the tumor is highly proliferative, very few cells dying. On the other hand, this population looks like it's probably fairly stable. In other words, the birth rates and death rates are quite similar. So how does that reflect? How do we look at this in terms of cancer therapy? Remember that I said that typical cancer therapy, and I showed this in androgen deprivation therapy in prostate cancer, maximum tolerated dose until progression. Now, in terms of many situations, initial therapy is really effective. And I spoke about androgen deprivation therapy, where the PSA became normal or even undetectable. Clinically, this is called NED, meaning there's no evident disease. The tumor is brought below the level that can be detected clinically. And yet, it's also not dead. We know historically that although we can't see the population, some microscopic populations still exist, and we can continue to give this therapy. They are resistant, as I mentioned, and so eventually they will sort of gather themselves, they will begin to grow again, and they will progress. This is the race to extinction. This is evolutionary rescue. This is progression, and this patient will assuredly die of the disease. What's interesting then is to look at the distribution of populations. So you'll see that initially, you've got a large population, it's also very diverse. You have a small population, way less diverse. And this is a vulnerability that we can strike at. As it gets bigger, it gets more diverse. And so this population is both large and more diverse, and therefore more difficult. And so can we see evidence for this? And this is where I think we see the best clinical evidence is in adjuvant therapy. So many patients, this is breast cancer, many patients prior to treatment, prior to surgery, are given some form of therapy, usually chemotherapy, to reduce the size of the population of cells and so that they can be resected more readily. And this is a very good example. This is a pre-treatment breast cancer. You can see the very abundant cancer cells spread throughout this area. This is the post-treatment. This is the tumor that was removed surgically after the neoadjuvant therapy. And you can see what's happened is that it's reduced a series of small islands of populations. These are not, they are no longer geographically adjacent to one another. These are highly vulnerable to it. This is the kind of population I think we need to be thinking about. So here, we consider the neoadjuvant therapy to be the first strike. The bad news is it wasn't totally effective. It did not cause extinction of the population. But the good news is that we now have a fragmented population that's small in number. These are probably fairly stressed because they're isolated and they're away from blood vessels. They cannot mutually support one another. And they're probably fairly homogeneous because they've been selected as the ones that are resistant to this therapy. So if we think about that again in terms of the cancer dogma, what we're seeing then is that you give a maximum tolerated dose, you continue to give that therapy until you see progression, meaning that it comes up above this clinically detectable range. Then you treat it again. The problem is that when you do that, the tumor population has grown and has become more heterogeneous. And so the probability of the second therapy eradicating it is actually very small. And so remembering that clinically detectable tumors is usually 2 centimeters in diameter, and since each cubic centimeter contains about 1 billion cells, to be able to see it clinically, it's a massive population, and it has become very heterogeneous. So what we would say is that this dogma, this we don't give another treatment until we can measure the effects. We've got to be able to see measurable disease. Waiting too long, it's losing the opportunity to treat this this cancer at its lowest level when it's most vulnerable to extinction. And so, can we see otherwise? And these again are simulations. What we see then is that instead of giving a second therapy only when therapy has the initial treatment has clearly been ineffective and you've got progression, is to treat even when you can't see it. You know that you've gotten a good result, but instead of waiting for it to come back, hit it immediately. Treat it again with a different treatment and use the extinction board. So one of the questions that comes up is, well, if this is your treatment, why don't we add that second treatment at the beginning? And the problem is that you're adding the second treatment when you've got a very large population, so that the probability that you will have subpopulations that are resistant to both is very high. And in fact, this is what's seen clinically. While adding one treatment to another can usually improve the outcomes in terms of increased time to progression, it is no more likely to be curative than with one treatment. On the other hand, adding that second therapy when the population is in decline is when it is most vulnerable to extinction. And so you can see this model prediction. So the idea then is to hit cancer populations when they're down. In other words, you've knocked it down, and instead of playing by boxing rules where you wait for it to get back up and be ready again, you treat it like a knife fight. Basically, when it's down, the other thing to remember is that in Anthropocene extinctions, the final nail in the coffin of an extinct species is rarely the same one as the initiated decline. In other words, the first strike that causes decline is very effective, but the second strikes, the ones that cause extinction, are not the same. And so this idea that you keep treating it is a poor idea. You need to change treatments. You need to take advantage of the allele effects and its vulnerability to stochastic perturbations. And so if we go back to the original things we were talking about, androgen deprivation therapy for prostate cancer, very effective. When do we change therapy? Well, right now it's here. When the PSA goes back up, we say it's progressed, and we give Abiraterone here. What we would propose is you give it here. The PSA is down. It's in effect. Maybe it's not even measurable. That's great, but we know historically that there's still cancer there. Don't keep giving the same treatment. That's futile. Take it away and give something else. Now, some of you may say, that sounds familiar, and it should be, because this theoretical strategy, it turns out, is identical to the empirically derived strategy that's been used to curatively treat pediatric leukemia for a decade or more. They give actually an induction therapy, which is the first strike. What they typically find after a successful first strike is that there's no measurable tumor in the bone marrow or in the blood. What they've learned historically is that if they don't do something, that tumor always comes back. Even if they can't find it, it always comes back. And so what they do is probably overtreat, but nevertheless, they add 3 second strikes, 1, 2, 3. And in this case, the cure rate is about 95%. Very rigorous treatment, but it is effective. And I would argue that what they're doing essentially is using dynamics from Anthropocene extinctions to cause a cure. And I believe that we can actually apply these to in a and the first clinical trial for this is now underway in pediatric. And a second clinical trial in prostate cancer is also about to get started. So we are actually trying to. How do we do this in the clinic? I would argue for the following: we need to define what's the outcome. Are we treating for cure or are we treating for control? We should not do both. We should not mix these. If you manufactured a pesticide in the United States, and I suspect this is true of Europe as well, you're required by law to include a resistance management plan for your pesticide. You cannot get it approved without that. We don't have that in cancer treatments, and we think we should, both for specific treatments and for each patient. There should be an explicit plan to understand what resistance we expect to see and how we're going to manage that. And then I think we need to perform after action analysis, like I showed you earlier. Using a mathematical model allows you to investigate not just cohort of patients, every patient within that trial, and so that you can learn from patients specifically what went wrong and how you could have done it better. You can also use this to analyze individual patients, so that we can, if the mathematical model is used, then you can always go back and see what you did. So with that in mind, Moffitt has established an evolutionary tumor board, and I'll just briefly, what happens with that board is that the oncologists that are consulting with the board first meet with a group of evolutionary biologists, mathematicians, and this is that kind of meeting. There's actually 3 evolutionary biologists, a mathematician, and me in the room, as well as the clinician. In the background, you can see the equations that were down to express the dynamics that we thought were present in the individual patient. Right now, this group is actually speaking to the patient by Zoom. And the evolutionary biologists and mathematicians then develop models for what they think is going on with the patient. And over the next 10 days, we'll run multiple simulations to look at various outcomes and various strategies. The formal evolutionary tumor board is run by oncologists and is attended by members of every program. And the patient is presented, and then the mathematicians will present their patients as advisories to the evolutionary tumor board, and the patient is discussed, and a recommendations. The physician has the can ignore that or can implement that, but in any case, this is actually also a formal clinical trial. So that patient will continue to be followed by the evolutionary tumor board. That person's clinical course will be mapped against the simulations. And so in this N of 1 trial, it allows us to look at every patient that's being treated, understand the outcomes, and also learn what we're doing right and what we're doing. And so that I will thank many people who have been involved in this, and I am happy to.
Thanks a lot to Bob. Can you hear me?
And yes.
Okay. So thanks a lot for a very stimulating talk. I encourage all participants to ask questions. We have already some Thomas Hill, can you ask your question from Canada? Thomas?
Okay, I had to unmute, so I think.
Hello, Thomas. Nice to see you.
Nice to see you, Bob. Thanks for a very stimulating talk. You focused on metastatic cancer, but I think the same adaptive ideas should be relevant for primary tumors. Is there a reason you focused on metastasis?
Well, because that's kind of been what we're interested in, but you are correct. We actually more recently have been thinking in terms of adjuvant therapy, because as you know, women with breast cancer, many people with lung cancer, who have advanced disease and are at risk for developing subsequent metastases, receive adjuvant therapy. And there the idea is explicitly to treat and eliminate small populations which we know are there but can't detect. And I think that's an area that we're increasingly interested in, because the results of adjuvant therapy demonstrate clearly that we can cause extinction of small populations with treatments that we have. But it also demonstrates that we're not really good at it. I mean, we can reduce the number, the fraction of patients that recur from, let's say, 40% to 30%, and indicating that we can do it, but it also indicates we're failing to do it in the majority of those patients, and we need to do better. And so I guess, so you're right. I mean, the dynamics of small populations are really critical to cancer treatment. I mean, we always talk about large populations because that's what kills people. But the fate of individuals, death or survival, often turns on small populations.
Thanks a lot.
So that kind of focus is something that we're interested in.
Thank you.
Thanks, Bob. There's another question from Mexico by Josue Nava Cedeño. Can you ask your question live, Josue?
Yes, of course. Thank you for the talk. So I was wondering about the last strategy, I think it was, where you need to administer a second treatment after the initial one so that you eradicate this population that is now very small. In order to determine whether you are already in this region where the tumor population is small enough to be vulnerable for extinction, you would need to have some follow-up checkups. And I was wondering, maybe in some countries or for some patients, it's not possible to go and have checkups and determine whether they are in that stage. So would it be possible to determine an optimum time for administering the second treatment, the follow-up treatment?
It is. I think there's many things we don't know, because this is not a dynamic that's really been recognized, and so much of this, unfortunately, means working in the dark. So, for example, we by definition, if you can't detect the tumor, you can't really detect the effect, and so that's always unappealing. There are technologies for serum markers that are developing, serum circulating DNA, other things which may become useful. But it is, and the fact that we can only get snapshots of the patient. We get a CAT scan of a patient every 3 months, every 6 months, but the optimum time for treating the tumor may be in between those things. And so there are many things to learn about this. We also know, for example, that the only treatments that are currently approved for a thing like prostate cancer are drugs that are effective in large, bulky tumors. But in smaller tumor populations, there may be drugs that are very effective, but have not been approved because they've not been tested in the right setting. So there's a number of things that unfortunately.
Mm-hmm. Thanks, Bob.
Fortunately, we have to learn as we go. I do think, though, okay, the population is in decline. I think you can give the second strike. I don't think you have to wait till it's absolutely
perfect. Okay, thank you.
Thanks a lot. Yes, we have a question from the YouTube channel by ZZ. Just a general question. Is it possible that the adaptive therapy strategies can prevent the tumors from metastasis? As most the mathematical models are ODEs, so how to deal with random noise?
The adaptive therapy is given only in metastatic settings. In a primary setting where we don't think where the tumor is potentially curable, we don't use it in that application. So that's, in terms of noise, I completely agree that there's lots of noise. It's biology. I mean, it's noise, and it does make a lot of and adding that and using it is something that's very difficult to do. I'm happy to talk offline about that.
Okay, thanks. There's another question by Hindi. Great talk. The resistant cell has the fitness disadvantage compared to the sensitive one. What is the reason for their coexistence? Is there any possible way to promote their competition to eradicate the resistance cell population?
Yes. What we think is that if you have a population in which there's, most of it is sensitive, the resistant group is some kind of subpopulation that is less fit and therefore smaller, but still there. So they do coexist for some reason. There are ways to perhaps punish the resistant populations before treatment, so that you can then have only a population that's sensitive when you start. And there have been people that have proposed that kind of strategy. Carl O'Malley is someone that has specifically suggested it, and he has a very appealing name for it, which I cannot remember offhand, but this idea of sort of manipulating the population to the benefit of the patient, then can take on any number of strategies. In fact, you can, once you get your head around this, you can sort of stay up nights thinking about diabolical ways to kill a cancer population, which can be actually enormously entertaining and cause a great deal of sleeplessness.
Thanks.
He calls it a fool's gambit.
Mm-hmm. So we have a question from Magda via Zoom. Magda, do you want to put your question live? Magda,
yes.
Where are you?
I can just unmute myself and okay, good. So I want to have a question regarding the prostate cancer part of your talk. I'm just curious because very often these cancer drugs have strong adverse effects. I was wondering how, shortening, sort of making this therapy on and off, how did it influence the adverse effects? Did patients see a lot of benefit, or how did it work for the patients?
Yes, this is androgen deprivation therapy is essentially chemical castration, and to say that men hate it does not do justice to how much they hate it. So we've in our current our trial using just androgen deprivation therapy, where we give it for a while and then we take it away. The men are very happy about that because it does retain, it reduces the toxicity considerably. And for men, this is quite severe. It can be osteoporosis. They can get fractures. And probably the women in the audience will not be surprised to know that men's cognitive behavior is reduced when testosterone goes down. So they also feel kind of goofy and unhappy. So that has helped a lot, and is one of the reasons that we have had very good compliance with the patients, because they recognize that even if they're getting this therapy and if they're getting side effects, that it's for a fixed period of time and then we stop it. And so that, I think, has made a big benefit.
And how did you manage to get it approved that it's actually tried in a clinic? Was it difficult to, because it's just a mathematical model, right? It's not a medical device.
Right. So the first trial, we kept the mathematical model out of the protocol because we didn't want the approval agents to, we just didn't want to raise that question. And it went through, you know, you have to remember, of course, these are fatal diseases. And so, and these are approved drugs. So using the approved drug in different ways, it's not necessarily that hard to get approved. But it's since then, we have a number of trials going on now. We now do add the mathematical model to the protocol and refer to it in the protocol. So we've actually gotten the different approval groups kind of aware of mathematics and its use in clinical settings, which has, I think, been quite a big step forward.
Yeah.
Thank you, Magda. From which country are you asking?
I'm from Germany, DKFZ Heidelberg.
Okay, thank you, Magda. And we have a final question by Yunus Asimzadeh. Are you there, Yunus? Can you ask your question yourself? Okay, I will do it for you. Thank you for a great presentation. As I understood, the lower fitness advantage of resistant cells allows other cells to eliminate them during treatment. Are those differences in fitness advantage big enough to lead extinction for all cases?
They are not, right.
Yeah. So the question.
No. What they do is keep the resistant cells from proliferating or reducing their proliferation, but they do not eliminate that population. But that's a good idea. And again, I would encourage people to sit up nights thinking about how we can do that. So there's certain things that we can do to further punish the resistant population, or to promote the cells that are sensitive. And so yes, I think all of those are possible. And it's really almost limited by imagination and time.
Mm-hmm. Sorry, do you hear me?
Yes.
As a follow-up to that question, since those resistant cells have already survived this harsh competition, how do we know that in process they will have a limited ability to proliferate and expand?
Sorry, I couldn't quite understand what you said. So the resistant cells have survived this sort of punishing environment, and then I kind of lost what you said.
Okay, so if they have survived, so
I think we have some technical problems now.
If you would like to email me, I'm happy to continue the discussion.
Yeah. So thanks a lot. I would like to come to the end, and I have also a question. You make a lot of reference, Bob, with organismic evolution. You take many ideas from organismic evolution, but how did it evolve your scientific thinking? Did you have the evolutionary ideas and later realize there are analog thinking in organismic evolution? or did you read books on organismic evolution and took the ideas for the cancer?
Actually, the beginning of this was working with a physicist, and we actually were using catastrophe theory, and we're talking about phase distinctions between the treatment and the treated cells, and how you could become dephased over time. And it was really later that I realized that that could be reframed evolutionarily. So it actually began as a rather obscure.
Mm-hmm. Mm-hmm. Is Moffitt the only hospital where where patients are currently treated with evolution-based therapies, or is this a trend which invades to other hospitals?
There's a few other places. So we just started one of our trials at Emory, where the dean of the medical school is very supportive of this, and we, a group at Fred Hutchinson in Seattle, just put in a grant.
Mm-hmm, mm-hmm. Okay.
For a protocol like this, and we have smatterings of patients here and there. So there's a few places doing it, but not very many. It is not something that is necessarily intuitively obvious to oncologists. So.
Yeah, we have people here in the seminar from DKFZ, German Cancer Research Institute. Maybe they can adopt some. But I think we have to come to an end of the seminar. I would like to thank you again, Bob, for your great talk. It was
Thank you for having me.
And we were very happy to have you as the final speaker. And with this, I would like to make a few final comments for the seminar. I would like to thank, first of all, to all the people participating in the discussions after the talks, all the speakers, and also the people behind the screen. So this was an idea in my group 3 months ago, and Robert, Simon, and Lutz helped to make it live. We had a couple of experiences, there were technical issues and so on, but personally I'm very happy that we came to the final end and there was a lively discussion. We have roughly 300 registered participants, and each talk was followed by approximately between 50 and 100 people via Zoom and YouTube. And actually many much interest after the talks was visible in clicks of the YouTube videos. We feel ourselves as an evolutionary project, so we have made now many experiences, and we would like to use these experiences to adapt the seminar series. There's an idea to continue it in the fall, because we had not only very much interest among participants, but also among speakers. And there are still some speakers in the row who will probably then speak in the fall. In order to improve, we will send out a questionnaire in August to all the registered participants, and we are very interested in your feedback, because we think that we have now a very nice crowd of people interested in the interface between mathematics, physics, cancer, and there is something we want to do with this interested crowd also in the future. So with that, thanks again, and I wish you a nice summer and hope to see as many as possible back in the fall. Goodbye. Thank you.
Thank you.